Okay, so like I said, this is a passion of mine, and it is as I did train in both areas, but it is also very important. I think it's important for people with Parkinson's disease, but also the general populace as well, because sleep disorders are so common. So hopefully everybody's awake after that stretching exercise, and we'll talk a little bit about how to get a good night's sleep. So I want to start off, there's no conflicts of interest. I want to thank the Parkinson's Society of British Columbia, also the National Parkinson's Foundation, and just acknowledge some of the collaboration I've had in various realms of research with Dr. Stossel, Dr. McEwen, and some of the other PPRC members. So what are we going to learn about today? Hopefully we learn a little bit about sleep physiology, because this is important to learn about disease as well as how to treat some of these various presentations. Learn about the diseases themselves, and then how to manage them. And why is this so important? So we know that in people with Parkinson's disease, there's about a 90% prevalence of sleep dysfunction. So this is, if not the most common, one of the most common non-motor presentations of Parkinson's disease or disorders that people will present with. About 1/3 of the average populace will experience insomnia at some point in their life. So this talk is applicable, I think, to everybody, including family members and caregivers. So what are the various pathologies, excuse me, that we see in people with Parkinson's disease and sleep dysfunction? A circadian rhythm, sleep-wake dysfunction, very common, and we'll go into a little bit of details behind that. Insomnia, probably one of the most common presentations. The opposite of that is excessive daytime sleepiness, so just hypersomnolence. REM behavior disorder, which we'll touch on a little bit later in the talk, and that is an area of research of mine. Restless leg syndrome, likely more common in people with Parkinson's disease, and we'll talk about management in that realm. And then obstructive sleep apnea. So let's start with sleep physiology itself. So this is, well, I'll explain why I have a cup of coffee there, but there's a couple of things that help guide our sleep. So one of them is the longer you're awake for, the more sleepy you become. So that's pretty common sense. But the reason for that is the longer we're awake for, we build a chemical in our body. It's called adenosine, and it builds and builds and builds. So if you're awake for 3 days, you're going to fall asleep. I don't care who you are or how bad your insomnia is, you're going to eventually sleep. And what coffee does is actually blocks that. So that's the mechanism of action, why it's a fatigue counteracting measure, or how it keeps you awake. It blocks that subtly. Taking a nap would do the same thing. Taking a nap would kind of just blunt it just slightly. Okay, so that's important when we talk about insomnia. The other important area of, or the big second branch that drives our sleep pattern is our circadian rhythm. So a circadian rhythm, so circa means roughly, dia, day, so roughly a day. So that's 24 hours. Every cell of your body and every hormone that's secreted functions on this 24-hour level. Okay, and we have very strong timekeepers in our body. The biggest one, or the strongest one, also called a Zeitgeber. So I'm glad Silky's not here because she would correct my German, but it's light. So, and not any, all light will help you, but the most powerful light in terms of the lux provided is sunlight. And if you look at just typical hormone patterns, like I said, everything runs on this 24-hour pattern. So in the mornings, you have a peak in cortisol, and then it slowly drops off throughout the day. This is a wake hormone. You also have other hormones like adrenaline, noradrenaline, and even dopamine. And at night, you see a peak in this red line here, which is melatonin. And during the day, it's pretty flat. So you hit your peak at about 3 or 4 in the morning for your melatonin levels, and your core body temperature is at its lowest point as well. So those are all normal hormones that fluctuate at a 24-hour level. And that's important because in people with Parkinson's disease, we know that there's an impairment in some of these neurochemicals. So there was a nice little study done by Dr. Vidnovic out in Harvard. And what he actually did was measured people with Parkinson's disease melatonin levels. I believe it was hourly. and he compared it to age-matched controls. And what you see on this graph here just simply is melatonin levels are much more blunted or reduced in people with Parkinson's disease. So it's not only just dopamine, but melatonin is significantly reduced. The other thing this study showed was people who had sleepiness during the day had even lower levels, I don't have the graph here, of melatonin. And so impairment in circadian rhythm is seen for this reason, but there's other reasons as well. Sleep difficulty at night will also disrupt your circadian rhythm. And then daytime variation in medications. Again, when you're taking medications, you always have to think of this diurnal pattern or 24-hour pattern. Circadian rhythm disorders oftentimes, or at least disruption in this physiology, will lead to the most common sleep dysfunction in people with Parkinson's disease, and that's insomnia. So insomnia, you can kind of break it down into 3 major categories: difficulty falling asleep, difficulty staying asleep, or waking up too early, so terminal insomnia. And this, well, there's several contributors to insomnia in people with Parkinson's disease specifically. Oftentimes, it's the tremor may get in the way of falling asleep. Rigidity or stiffness, even pain and discomfort, could get in the way of sleep initiation. Restless leg syndrome may also contribute. Dyskinesias, Silky probably covered that earlier today. That can also contribute. And then changes in neurochemicals like melatonin, like I mentioned. A big feature that we oftentimes see is racing thoughts or anxiety. So this occurs right across the board. It's probably one of the most common causes of having difficulty falling asleep at night. People just lie in bed and the mind is racing, and they use that time kind of to get out their stress through the day, which is not ideal. The main causes of sleep maintenance dysfunction, so difficulty staying asleep, include, especially in Parkinson's disease, stiffness and discomfort through the night. Sleep apnea, although it's not listed here, is a very common cause of difficulty staying asleep. If you imagine your airways occluding every once in a while, you're going to be having multiple arousals through the night. And poor mobility in bed, we've touched on that, and then difficulty turning in bed as well is a common feature. So treatment for insomnia. So this one's tricky. My preferred management strategy is something called cognitive behavioral therapy for insomnia. So essentially a lot of this is education on, we talked a little bit about sleep physiology and using those mechanisms and employing this CBTI program rather than simply just using medications. We can use hypnotics and other types of sleep aids. Those are more of a last resort. So one big concept here is the only 2 things you should do in bed are sleep or sex, okay? And some people are a bit more stringent about that than others. Some sleep experts say sleep only. I think it's tricky, or it's hard to just ask for that. Regardless, you should only go to bed when you intend to fall asleep. And if you're awake for more than 15 to 20 minutes in bed, you should actually get up and go do something boring or monotonous in another room. The reason for that is what you're trying to do is break that association with being awake and in bed and reacquaint yourself to that environment. So the only thing you should be doing, ideally, would put your head down, 2 minutes goes by, you fall asleep, you wake up, and you go about your day. And what that does is your sleep efficiency, so the time in bed, is very high. So that would be ideal. Most people don't do that, but it is something that we would strive for, especially if you have insomnia. So that's one of the big strategies. When you do leave the bedroom environment, if you need to, because you're just lying in bed, your thoughts are racing, you can do something monotonous in another room, as mentioned, but definitely avoid electronics or any other bright lights, because what that's going to do is reset your circadian rhythm. It's going to tell your brain it's the morning time, it's the time to go hunt, forage, scavenge, kind of do all those things you're supposed to do during the day. So you definitely don't want that at night. And so when sleep finds you, you can go back into the bedroom. Keep a fixed wake-up time 7 days a week. A lot of my patients hate me for recommending this. This includes weekends. So what this does, again, is you're using that circadian rhythm and you're really trying to entrain it or entrench it to a nice schedule every single day. And if you don't have any problems with your sleep, you don't have to employ these strategies, but this is for people who do have significant insomnia. So pick a time, whatever's comfortable for you, and wake up at that time every single day, irrespective of weekends, irrespective of the amount of sleep you have. And then another big driver is avoid napping. If you avoid napping, that chemical is going to build up more, and you're going to have more sleep drive at night. So you're going to sleep more when you should be sleeping more, when you want to sleep more, ideally. Extra helpful hints specifically for people with Parkinson's disease. Dopaminergic therapy overnight actually may help. There's a couple of reasons for this. If you're turning in bed a little bit less rigid, you have less discomfort, this would improve quality of sleep, decrease arousals. So ideally sleep maintenance would be improved. There's a study that suggested that if you're able to turn in bed, then your airway is a bit more protected. And it makes sense. If we're lying on our back, things are a little bit worse in terms of our airway. So if you're able to turn a little bit more, then you're a bit more protected. Other little helpful strategies, you can use sand sheets or silk sheets. It helps move around. A lot of people with neuromuscular disease find that that's helpful as well. Really soft beds, again, it depends on your level of mobility, may not be ideal because you may feel stuck and rigid. Again, people with neuromuscular diseases have difficulty in really soft beds. Melatonin, as you can imagine, may improve sleep quality. We don't have great evidence for this. We use it to treat other sleep disorders. But every once in a while, if people are having some difficulty in their sleep, I will try it out. It's not really all that harmful at low doses. And then again, you'll hear this time and time again, bright light exposure in the morning. So you want to expose yourself to bright sunlight ideally. Hard to do here or even in Vancouver, but some type of bright light, and even try to exercise, go for a walk, do something to reset that circadian rhythm, kind of get the brain into that normal hormonal level. And so we've touched on a lot of these strategies when going through sleep hygiene. There's very similar principles. So keep a regular wake-up time. A couple other things that are extra here. Empty out your bladder before going to bed. Don't go to bed hungry typically. Limit your caffeine intake. So when we're talking about coffee, I suggest don't have coffee past noon if you do have insomnia. Avoid alcohol in the evenings. The reason for that is, although it puts you to sleep, it actually is pretty bad for your sleep overall. It makes you just skim the surface, so your quality of sleep is pretty poor, and it causes a rebound insomnia. So you'll actually wake up more often, or may even have an episode where you wake up and you're kind of awake for the entire night. So alcohol is not great for sleep. And keep the bedroom quiet and dark, comfortable temperature. So in terms of comfortable temperature, people usually sleep a little bit better when they're colder at night. So that's something that people can somewhat target. Minimize blue light. We've touched on this. So I usually suggest 1 hour before sleep, avoiding electronics. So this computer here, iPads, iPhones, they all have enough lux in terms of the power of light that can reset your circadian rhythm. So you want to avoid that. TVs aren't as bad, but still not ideal. TVs in the bedroom, not a good idea. TVs are a little bit farther away, but they still have enough that they are changing your circadian rhythm. People always ask me about e-readers. So there was a recent study 6 months ago, I believe, that suggested even e-readers in a normal population change your melatonin level. So if you already have a low melatonin level, it may further disrupt that. And exercise. We all know how important exercise is for your circadian rhythm, but also in general for people with Parkinson's disease. So the opposite of insomnia is excessive daytime sleepiness or hypersomnolence. So this is a persistent sleepiness throughout the day, likely interfering with functioning. And this has to be distinguished from general fatigue. So we're just going to focus strictly on sleepiness itself, which is the propensity to fall asleep. And there's many causes for this, especially in people with Parkinson's disease. We have loss of wake-promoting chemicals, which we've touched on. Disrupted nocturnal sleep for various reasons will cause daytime sleepiness. And then the big one that we should focus on is dopaminergic medications. Cinemet, one of the major side effects is sleepiness. More so, dopamine agonists are notorious for causing people to have sleep attacks or just having excessive sleepiness. It's not common, but we definitely see sleep attacks with dopamine agonists. So how do we treat excessive daytime sleepiness? Well, a lot of this is common sense. If you improve nocturnal sleep, you may reduce your daytime fatigue and hypersomnolence. Exercising during the day is going to be a fatigue counteracting measure. Social engagement or interacting with other people. We know that when we communicate, when we eat, all of these are wake promoting events. So socializing is very important. Stimulating mood medications is another option we often employ. So if there's concurrent depression or mood dysfunction, you can use an alerting mood medication, and you take that in the morning. There's a whole host of them. One of the more common ones is Effexor or venlafaxine, but there's a whole host of very alerting antidepressants. Caffeine is okay, unless you have, like I said, significant insomnia, but for a fatigue counteracting measure, it's actually a good method. It's safe. There's been various caffeine studies in people with Parkinson's disease, but just in terms of as a fatigue counteracting measure, 1 or 2 cups is fine. Don't have it past noon. That's typically my advice. And then the last step, like I said, is reassess dopaminergic medications to see if they are significantly contributing to somebody's sleepiness or excessive daytime sleepiness. Okay, so this takes us to the next category, which is a bit more my area of research and interest. So this is REM behavior disorder. Most of you have probably heard of this. So this is abnormal movements or vocalizations in response to dreams at night. It can occur years before the onset of symptoms, or at least motor symptoms of Parkinsonism. And it is typically associated with very early low brainstem changes. When people have these complex behaviors at night, it typically, not always, occurs later on at night. So this is 2 a.m. or later, typically. The reason for this is you spend more time in dream sleep as the night goes on, as this chart shows. And so oftentimes if you wake up early in the morning, you remember your dreams more. It's not that you are remembering your dreams, it's actually you have a higher chance of being wakened from REM or dream sleep. So some of the clinical features of REM behavior disorder. So we have abnormal dreams, so the mentation of dreams is changed. And people will say sometimes it's a bit more vivid, sometimes it lingers with people a little bit longer, not always. And oftentimes dreams can be frightful. So a couple of studies have looked at this, and there's about 60% of people who will describe some event about being attacked or harmed by somebody else. And oftentimes you see defensive postures or people fighting back. Being attacked by animals is another common theme. More pleasant dreams like sports or adventure dreams are actually far less common. You're looking at about under 10%, unfortunately. Oftentimes we do see abnormal vocalizations, and again, the big distinction here is this is in response to dreams. So there can be yelling, swearing, just grunting, or even sleep talking. So sleep talking is a very common manifestation right across the board in all people, but if it's happening in response to dreams, it raises my suspicion. If it happens in somebody who has Parkinson's disease, then it most likely is REM behavior disorder. So in terms of other clinical features, you see abnormal leg movements. Again, I'll show you some videos just to kind of get a better understanding, but punching, kicking, defensive postures, some people jump out of bed. The interesting thing about REM behavior disorder, people will wake up pretty easily overall. It's not like a sleepwalker where it's sometimes very difficult to wake them up. So here's an example. So this is purposeful movement. Obviously, he's striking out. Many bed partners may recognize this type of behavior that occurs. People don't often, who are engaging these behaviors, don't often acknowledge it or know what's happening. And this should be distinguished from something like sleepwalking. So this is a patient who has sleepwalking combined with sleep-related eating disorder. So it does look very distinct. So it doesn't look like it's intentional or interacting with dreams itself. It's obviously eyes awake, or eyes open, sorry, walking into different directions. They are asleep, but this is a very distinct phenomenon. So sleepwalking itself and sleep eating and other behaviors are pretty common at night. So try not to, or try at least to distinguish those two. Again, the big distinguishing feature is it in response to dreams? So this is the video that would have been ideal to have audio. So this is a gentleman, I think it was a nice little clip where you see some vocalization. So I'll try to turn this up. So he's yelling at this point. Yeah, we're not going to get any audio, unfortunately. And essentially what he's describing is how unpleasant his dreams are. He actually says that his dreams are swirly gray figures that are attacking him every night, and it's quite unpleasant. He says it actually reminds him of the painting, The Scream, which I showed in one of the earlier slides. And you see how frightful he is as he's screaming out, as he's interacting with these. He does describe this as, it's almost like he's going or reliving an episode of a horror movie each night, unfortunately. This was some photographs from a paper I published from a patient of mine down in California who had very difficult to treat REM behavior disorder. So, and this just stresses that oftentimes people can injure themselves from these behaviors. So this gentleman had his mattress on the floor. His room was completely empty. He was in a sleeping bag so that he wouldn't move his arms and legs, and he was still launching his head into the wall, and he had put a couple of holes into the drywall, unfortunately. So we were able to get his RBD, or REM behavior disorder, under control, but it was difficult. It took a while. So how do we make this diagnosis? Well, the first step is to actually have a sleep study and distinguish. This is a healthy control, and you see that might be a bit tricky to see there, but the chin EMG, which is the electrical activity on the chin, is completely flat, and that's what you want. You actually should be paralyzed when you're in dream sleep. This is a person with REM behavior disorder, and you see there's a lot of extra activity that's occurring, while you would expect just a nice straight line because they should be paralyzed. So this would be diagnostic, at least based on the electrophysiological data of loss of paralysis, which is a key component to REM behavior disorder. So the prevalence is not truly known, and the reason for this, well, one major reason is a lot of physicians, including specialists, don't even know about this disease. They haven't heard about it. Most people with Parkinson's disease have heard about it, and over the years, this has garnered a lot more attention, but it was only in the late 1980s that this was first described. There's about a 5-year lag between symptoms of RBD to motor symptoms of Parkinson's disease. And for whatever reason, men are affected more often than women. This doesn't really make sense because we know the prevalence of Parkinson's disease is fairly equal, maybe just slightly higher in males. The reason for this, likely, or my theory is that women are maybe vocalizing at night and maybe going through some posturing or some complex movements, but the husband or bed partner is just sleeping right through the night, doesn't notice it. That's probably what's happening. So this is an unfortunate disease. However, we can try to gather a lot of information from this disease. And the reason for that, like we mentioned in the introduction, we can use it as a biomarker. So if this is occurring 5, 10, even 30 years before the motor symptoms of Parkinson's disease, then this is the perfect model to actually look for early treatment. So once we have a cure for Parkinson's disease, this would be a great group to target before there's any symptoms whatsoever, at least motor symptom-wise. And this is a PET scan. So this was just a control here on the left, but you see this patient was scanned initially when he was just diagnosed with REM behavior disorder. 5 years later, he had more features of, he developed a mild tremor as well as some motor features. And you see that there's loss of this color here, which is the dopamine activity in the striatum, or part of the basal ganglia. So this pattern, it is variable in terms of when people with REM behavior disorder will present with Parkinson's disease. but we know it's about 80% of people who have REM behavior disorder will go on to have Parkinsonism. So how do we treat this? One is obviously preventing injuries and avoiding injuring the bed partner themselves. And ideally, you'd want to diminish those unpleasant dreams. We do have medications for that. But the first step, like I said, is always bedroom safety. So bedroom safety is paramount. So removing all weapons from the bedroom is key, whatever those weapons are. And these are always longer conversations. When I was down in California, in Canada, people kind of look at me and say, I don't have a gun under my pillow. So you remove breakable or sharp objects from the room as well. And if the bed partner is in danger, then you can have them sleep in another room or somehow separate that sleep environment. Oftentimes, people just kind of put a wall of pillows. Heavy drapes on the curtains, I typically recommend, not because people defenestrate or go out the window. It happens more often in sleepwalking, but because people have broken glass and they can cut themselves. After that happens, though, like I said, they typically awaken pretty quickly thereafter. In more severe cases, we lower the bed, so mattress on the floor. We can consider bed rails. I find the bed rails, sometimes people can get caught up in them at night. So I'm moving more towards recommending sleeping bags because you suppress some of the movements and you have far less of people kind of getting entwined in those bed rails. In terms of medications, we have two good medications. Clonazepam is actually very good for this. It's good for two reasons. It actually suppresses dream sleep. Sorry, doesn't suppress dream sleep. It actually dampens the dream generator, so you actually probably dream a little bit less. You recall unpleasant dreams a little bit less, and it treats the actual movements themselves. Sometimes, though, people can't tolerate clonazepam. It's a little bit sedating. If there's any cognitive or memory changes, it can make that a little bit worse, and it is a little addictive. Low doses is typically safe, but again, for those reasons, oftentimes we have to use melatonin. Melatonin doesn't change dreams. Some people tell me it actually makes the dreams a little bit worse or changes the quality, but it does help actually suppress some of those movements. In my experience, I would say it's not nearly as potent as clonazepam or effective. All right, let's move away from REM behavior disorder and talk about restless leg syndrome. So restless leg syndrome is the urge to move the legs. So it's a creepy, crawly sensation, typically worse at night, improves with movement. Long car rides, long plane rides where you're stuck in one position can be pretty excruciating. And oftentimes, like I said, stretching or movement will improve these symptoms. In people with Parkinson's disease, this is an interesting phenomenon because oftentimes people are already on the treatment for restless legs, which is dopaminergic or some type of dopamine agent. So I do think that oftentimes it's actually just wearing off of this medication. So it's more of an akathisia or internal discomfort that people are experiencing rather than true restless legs, but we do see a bit of both. So how do we treat this? Well, the most important thing, because oftentimes you're already on a dopaminergic agent, which is a good therapy, you just have to change the timing of the medication and maybe provide more protection overnight. So that includes dopamine agonists as well as levodopa-carbidopa. And then at times we can add another first-line agent. Gabapentin is considered a first-line agent for just restless legs in itself. And we have used that in the past. Exercise is very important, gentle stretching. Massages are somewhat useful. So it's a good excuse to get your bed partner to kind of give you a leg massage. But yeah, so those are all kind of conservative measures. The last sleep disorder, and we have some time here, is obstructive sleep apnea. So obstructive sleep apnea, by definition, is if your breathing stops more than 5 times per hour. And this can be variable. The worst case I've ever seen was somebody who stopped breathing 140 times per hour, every hour, every night. But it has to last 10 seconds or longer, these pauses in your breathing. And oftentimes we see associated oxygen drop. So the oxygen goes down by 3%, and then it can lead to sleep disruption. And by that, I mean, if we're measuring your brain waves, you go from deeper sleep to a very light sleep or maybe even completely awake. So in that respect, it can definitely contribute to sleep maintenance dysfunction because it's causing multiple arousals. You may not even be aware of the arousals, but it can be quite detrimental to your sleep. Snoring is often a symptom, as I think many people have experienced here in this room. Okay, so obstructive sleep apnea, it's somewhat controversial whether or not this is more common in people with Parkinson's disease. Some studies suggest that we see it 20% more often. Some researchers feel that it's maybe just at the same rate in the general population as in people with Parkinson's disease. Regardless, it is something we should consider looking into or at least managing. It is present because there are certain health risks that are associated with sleep disorder breathing or obstructive sleep apnea. Heart disease, stroke, hypertension, and then all the other things where it disrupts your sleep. So it can cause daytime sleepiness by disrupting your sleep, and it can cause insomnia as well. So what is the treatment for obstructive sleep apnea? Typically it is CPAP. This is what the CPAP companies want you to think when they see CPAP, which, they're very comfortable. Look how happy she is. But when people think about CPAP, this is actually more often what they think. And unfortunately, it does have some negative connotations, and it is a difficult therapy, I have to admit, to get used to, but it is an excellent therapy. It doesn't have really any adverse effects. It's just air that's opening up your airway, essentially. So it's a great therapy. You just really have to get used to it. And nobody wants the Darth Vader mask, but we can use smaller masks, little nose pillows. But for whatever reason, people can't tolerate CPAP. There are other conservative measures of treatment. So one is avoiding sleeping on your back. So we know if you're lying on your back, your tongue is going to collapse more. If you're in dream sleep, everything gets worse and everything collapses further back. So sleep on your side or sleep on your tummy, and that actually would help, and maybe by 30%. Mandibular advancement device, I don't use this too often in people with Parkinson's disease. You're using the dentition or teeth and moving the lower jaw forward with a little kind of device. So oftentimes, just because of dental issues, it's more difficult to actually use that as a brace. It's probably better for a younger population. Other advanced PAP therapy, so positive airway pressure, we have bi-level therapy. Those can sometimes be more comfortable than CPAP. So those are all very good options. Other conservative measures, so we have weight reduction. And this all depends on whether there is excessive weight. So abdominal weight will prevent the diaphragm from moving down. Weight around the neck is actually a big contributor to this. So the more tissue you have around your neck and your neck circumference, if you can lose that, it actually can be quite helpful. So 10% reduction in weight in somebody who is overweight can improve snoring by about 50% and can improve sleep apnea by about that same amount. So small reduction in weight oftentimes provides big benefits in terms of your breathing at night. Reducing alcohol is an important factor, especially before you go to sleep. Again, like I've said, alcohol disrupts your sleep, but it also dampens your airway. So it makes everything floppy. So people, if you had a glass of alcohol before you go to sleep, you probably notice you snore more. Again, everything's a little bit more flaccid and flopping back on itself. And smoking, there's some suggestion that it actually worsens your airway at night as well. So in summary, insomnia was the first topic we discussed, and this can be managed oftentimes by cognitive behavioral therapy and proper sleep hygiene. REM behavior disorder, a very interesting pathology, but can be quite serious, and we do have to ensure that there's bedroom safety, but also this is something that we can look into for future therapies. Restless leg syndrome, oftentimes we can get away with just changing the timing of medications to improve this uncomfortable sensation. And then finally, obstructive sleep apnea should at least be considered, especially if there is a history of heavy snoring, gasping, choking, or pauses in your breathing. And again, we have various ways of managing that.